Hello and welcome to another week of Psychopharmacology. This week we're going to be talking about chapter 10, and this is the chapter about marijuana. So again, we're talking about a sedative drug when we talk about marijuana. It is an illicit psychoactive drug that comes from a plant, the cannabis plant, and individuals could use it in various forms, typically smoked though. So marijuana is dried and then crushed leaves are smoked. It is the most widely used illicit or illegal drug in the United States. And in this chapter, we're going to talk about medical uses of marijuana itself or medical uses of other products derived from marijuana. So cannabis sativa is the plant source of marijuana and hashish. It's a hardy plant, and it was actually widely grown in Kentucky where we are. And so you have a lot of historical uses of the same plant for other things, not just illicit drugs. The plant is used for ropes and sails and fabric and that sort of things historically. And the chapter talks a lot about that. The plant is like a plant, like the tobacco plant, in that there are lots of different chemicals in the plant. In this plant, there are about 60 chemicals that are cannabinoids that bind to the cannabinoid receptors in the brain. The main psychoactive ingredient is THC, or delta-9 tetrahydrocannabinol, and that's the psychoactive compound or the psychoactive chemical in the plant product that people are using it for the illicit use of the effects to get the changes that they want to experience. There are other things in the plant that may be useful for different medical conditions and things like that. And we'll talk about that in a moment. Because the drug is coming from a plant, the plants can differ. And so the amount of THC in a plant can actually differ quite a bit, ranging from on the low end, maybe 1% THC up to 20% THC. And so, like any plant, you could, grow it in certain growing conditions, and that will increase THC, or you can, breed different plants and get different THC levels. So in the United States, just to clarify about the legislation, because it is a little bit confusing and very much in flux from moment to moment. So synthetic THC-based medicines, synthetic meaning we make them in a lab, those are Schedule 3 drugs. So those are drugs like Marinol or Sesamet. The plant-based cannabis of any form is Schedule 1, meaning no acceptable medical uses, and it's just considered to be an illegal illicit drug. So there's no reason to use it. But that's the federal level. The state laws do differ from the federal laws, and federal laws trump state law. So the federal law is more important than what the state says, but a lot of times there's considerable inconsistency, and a lot of times federal law enforcement don't do anything about the Schedule 1 use of the drug in a state, and they just kind of stay out of it. This inconsistency eventually should get resolved, and it would be ideal if it gets resolved, but right now we're not at that place. So when you look at the use of marijuana, it is the most widely used illicit drug. Males use more than females, and you have differing use. Some marijuana users are using the drug daily. You have about 15% of individuals who probably fall in that category. If you look at high school seniors reporting past year use, about maybe a third. How people use the drug different ways, depending on whether they're using it just for the psychoactive effects as an illicit drug, or they're using it for other reasons, like maybe medical uses. So inhalation is very rapid and efficient because you're absorbing the drug through the lungs, where there's quite a bit of blood supply, and the effects will be felt within minutes in that form. But then you could also put the plant product in a food source and eat it. And so or you could have a pill form like synthetic THC, like the Marinol that I just mentioned, the Schedule 3 drug. When you do it oral administration, then the onset of the drug effect is much slower and less efficient because everything has to go through the digestive tract. And so in that case, you may not see onset of the drug effect for 30 to 60 minutes. So people use the drug illicitly just because they are interested in the psychoactive effects, which I'll mention in a second, but medical uses of marijuana increasingly are becoming more of interest to scientists to try and understand if this plant or the synthetic version of THC in some form or another would be useful for different medical conditions. So the first one that I'll mention is multiple sclerosis, and the muscle spasms that are painful or debilitating in MS. Marijuana is useful to help those individuals, and it seems to calm the muscle spasms. Pain, especially chronic pain, the pain that you would have to use opiate drugs to treat, like morphine, in some cases, marijuana use will also significantly decrease pain and also significantly decrease the emotional aspect of pain. And marijuana or the synthetic versions also really seem to be helpful in pain conditions. And that pain can come from a variety of sources. It can come from a chronic injury, it can come from cancer, it can come from lots of different ways. Muscle spasms, again, useful, and glaucoma. So increased eye pressure, glaucoma can be very dangerous. It can actually lead to blindness. And individuals who use marijuana, the pressure in the eyeball is reduced. That interocular pressure is reduced. And so that can be helpful. If you look at different published studies on glaucoma, though, there's sort of mixed response from physicians who treat glaucoma. So in some cases, they don't consider this as the first way you would want to treat glaucoma in a patient. It also significantly decreases nausea and vomiting, which is very helpful in conditions like AIDS and cancer. It also helps with the wasting syndrome called cachexia. That can be a predictor of death in a cancer patient, for example. If you can get marijuana in whatever form or synthetic marijuana in the person, their appetite improves, they gain weight, and then they often have longer lifespan. Marijuana use in a recreational user would make people hungry. In a cancer patient that is losing considerable amount of weight, it can be life-saving. So let's think about the acute effects first. So immediate effects of marijuana. Objectively, it's a sedative. You'll see sedation type effects. You will see cognitive and behavioral functions looking impaired, decreased attention, increased errors on psychomotor tasks. If you watch people driving, they look impaired. They may just drive more slowly. They tend to not have very good memory. So memory impairments, aggression is reduced. All of these are sedation type effects. And then the increase in hunger is reliable as well, which I just mentioned might be helpful for certain patients. Subjectively, what do people report? And the effects are quite variable. It depends on the person, their experience with marijuana. It depends also on the situation, the environment. So sometimes people will report not much at all. Sometimes people will report feeling high or euphoric, mellow, drowsy, relaxed, carefree. They may feel sort of talkative, loquacious, maybe laughter is, they're, in a good mood, easygoing. Perception of time is altered, and that's a reliable effect, so much so that people are looking at that as a way to measure the use of marijuana in drivers, because it's so reliable, the perception of time alteration. And then depending on the person, sometimes individuals will report anxiety or panic attacks or paranoia. And so not everything is feeling high and carefree, sometimes you can have some significant negative effects. And that is concerning if you're looking at this as a medical treatment as well. When you look at the acute effects, you might see things like red eyes, decreased intraocular pressure I mentioned a minute ago. The mouth may be dry. Skin might have sensation of heat or cold, increased heart rate you might see, and muscles relaxed. So those were the immediate or acute effects. What about chronic use over time? Well, the research is sort of mixed in this area. So sometimes you see that chronic users have cognitive deficits and memory problems. In some cases, it's not known if these were pre-existing conditions or the drug induced that over long-term use. It is in some cases associated with mental health problems. And again, you have the same issue. It's difficult to establish the causal effects. Someone who experiences psychosis, is it because the use of marijuana induced psychosis, or did they have psychosis predisposition and then they used the drug and then you saw symptoms after use? Lung problems may occur due to smoking, just like smoking cigarettes is associated with health problems in the lungs. There are also negative effects on reproductive function and fertility. And so if individuals want to have children, the use of marijuana would be potentially a deterrent from getting pregnant. There are negative effects on pregnancy outcomes, and just like with smoking cigarettes, you see some small birth weight and things like that. And then amotivational syndrome is something that has been seen both humans and animals, just not motivated. So a monkey would normally work pretty hard to get treats, and monkeys who've been exposed to smoking marijuana, they're just not interested. They lack motivation. Just like humans who chronically use marijuana just seem to lack any motivation to do anything, to achieve anything, to push for a career or anything like that. So it's not just humans that you've seen this effect. You've seen this in animal studies as well. And it can be disconcerting to know that, that might lead to some long-term outcomes. What about tolerance? Users do not seem to increase their dose over time, which is a good thing. That seems to indicate that you might get some tolerance, but it's fairly limited. This is very different than the last chapter where we talked about opiate drugs leading to very rapid tolerance within like even a week of use. So when you're talking about treating pain, you could get very rapid tolerance to morphine within a week of daily use. You would not see that with Sedative or Marinol, the synthetic versions of marijuana used to treat pain. So that's a consideration if you have to treat somebody's pain over a long period of time. And then also the tolerance for the acute effects go away when the drug is stopped for marijuana. What about dependence and withdrawal? So the risk of dependence is estimated to be about 9%. It's much lower than other drugs. That's a consideration. Withdrawal symptoms, again, very variable. For some people, nothing. They don't feel anything. They just stop using and that's that. Other individuals have limited physical symptoms if they stop using. So say they were a daily user and then they stopped. It's not aversive like other drug withdrawal symptoms. So the person may feel irritable, somewhat depressed and restless and agitated. And that might sort of start 1 to 3 days after stopping using and last for about 2 weeks, but not nearly so serious and not often something that requires inpatient treatment. So if you think about withdrawing from alcohol, that's actually really dangerous. You would want to be in a medical setting if you were a very chronic user of alcohol and you suddenly stopped. Opiates, you may not die from withdrawal from opiates, but boy, are you going to be miserable with all those flu-like symptoms. Here, we're talking about another sedative drug, but the withdrawal is really very mild. So just to compare those 3 classes of sedative drugs for you. Pharmacology. So the site of action, THC, the active psychoactive ingredient in marijuana, binds to cannabinoid receptors, and there's CB1 and CB2 cannabinoid receptors. Those cannabinoid receptors are found throughout the brain, except the brain stem. So that's where you breathe, your breathing and heart rate center. So as a result, if you use marijuana, it's actually impossible to overdose because the marijuana does not affect the breathing and the heart rate. So that's an important thing to note. Anandamide was first isolated in 1992. So a lot of the research is really new, which is kind of an exciting area to understand how these cannabinoid receptors are working in the brain, what anandamide is doing. The more research that comes out is just escalating every year. We know that it plays a role in appetite, obviously, because we know the effects of the drug cause people to want to eat. It affects sleep, memory, concentration, time perception, pleasure, and pain perception. So the amount of work in the next 10 years on anandamide and cannabinoid receptors is just going to be incredible. And, you know, I'm kind of excited to see what we learn. And the other thing is that these neurotransmitter systems don't function in isolation. Cannabinoid receptors also alter the activity of endorphins and GABA. And so, you know, that's the other piece that will become more and more important to learn about is, you know, how does it affect the endorphin system and GABA and things like that. So here's just an image where it's showing anandamide produces its effects by activating cannabinoid receptors of the postsynaptic neurons, and THC acts by activating those cannabinoid receptors. So again, maybe a little bit simpler to understand than some drugs. So pharmacokinetics, the drug is distributed throughout the body and the brain, and metabolism is actually rather slow, and it's really slow because THC is stored in the fatty deposits of the body. And so you can detect metabolites of THC in the urine for about 3 weeks. So, you know, when I drug test in the lab, if any drug screen ever comes back positive, it's always the marijuana, the THC drug screen, because people will stop using, but then it's still in their fat. And then when the fatty deposits get released into the body, then you see some, you know, THC showing up on the screen. And so that's why, for example, you might have sports athletes who are tested randomly, testing positive for THC, even though they hadn't used for a while. Now, lastly, about treatment. Few patients seek treatment for marijuana dependence. If you were to go into a treatment facility, you would probably not find any individuals who are there for marijuana. The reason is when you stop using, it may result in some depression, some craving, but it's not a devastating withdrawal syndrome. And as a result, we don't really have any direct pharmacological treatments for marijuana users. Sometimes if they're depressed, we give antidepressants, but that's about it. Cognitive behavioral therapy or motivational incentives have also been used as psychological therapies, but for the most part, it's far less of a drug that causes significant problems in our society. And so as a result, we don't have many treatments because we don't seem to need them compared to maybe alcohol dependence and opioid dependence, the previous 2 chapters that were also sedative drugs. And that's the end of that chapter. Have a great week, everybody.